Hi everyone, this is Pedro Gonzolez from UT Southwestern. I'm going to present the case preemptive alcohol septal ablation prior to valve-involved transcatheter mitral valve replacement with bioprosthetic balloon fracture. The case entails a 78-year-old female who underwent a surgical mitral valve replacement with a 25 mm mosaic bioprosthesis in 2004. She immediately developed mild dynamic LVOT obstruction. She was experiencing progressive heart failure symptoms refractory to medical therapy at the time of referral to our institution in 2019. Echo showed severe bioprosthetic valvular degeneration, resulting in significant mitral stenosis, a velocity of 4.6 across the LVOT, and a subaortic septal thickness of 16. She was not a surgical candidate due to her multiple comorbidities and frailty. Valve-involved TMVR is an acceptable treatment option for high surgical risk patients with severe valvular degeneration of mitral bioprosthesis, and its use is increasing. It carries an inherent risk of acute LVOT obstruction in patients with predisposing anatomical factors, like our patient with a mild LVOT obstruction at baseline and anticipated bioprosthesis valve fracture. A preemptive alcohol septal ablation is emerging as a promising and safe strategy to allow for basal interseptal myocardial wall remodeling before the TMVR to prevent this LVOT obstruction. Application of this strategy prior to valve-involved TMVR with a bioprosthetic valve fracture has not yet been reported. A CT angiography was used to create a multiplanar reconstruction of the predicted neo-LVOT in end systole. A neo-LVOT area of less than 189.4 is usually considered high risk for LVOT obstruction post-TMVR. Our patient's neo-LVOT with a S3 valve was 252.4, which is above the conventional threshold, but still concerning given the anticipated valve fracture. After discussion with the interdisciplinary team and the patient, the decision was made to proceed with a preemptive alcohol septal ablation strategy. Here in Figure 1, we can see a CT angiography of the mitral valve reconstruction. Using a computer-aided modeling of the neo-LVOT with an S3 valve showed a predicted area of 252.4. Here in Figure 2 shows the performance of the preemptive alcohol septal ablation. This coronary angiography shows the balloon occlusion of the second septal perforator prior to injection of the alcohol septal ablation in a standard fashion. Figure 3 shows two TTE parasternal lung axis views. Panel A shows the TTE prior to the alcohol septal ablation, showing the dynamic obstruction of the LVOT by the anterior portion of the bioprosthetic valve, which protrudes against the septum and systole. Panel B shows the echo 4 weeks post-ablation with a substantial reduction in the thickness of the basal septum and no significant LVOT obstruction in systole. A transseptal valve-involved TMVR was performed 5 weeks after the alcohol septal ablation. Immediately following the implant, a mean gradient of 8 was noted across the TMVR valve and none across the LVOT. A bioprosthetic valve fracture was then performed under rapid ventricular pacing. The fracture was confirmed by the release of the balloon waist and sudden drop in inflation pressure. The mitral gradient was reduced to 5. There was still no gradient across the LVOT. Figure 4, we can see the deployment of the valve-involved TMVR with a 23 S3 valve. Movie 1 here shows the bioprosthetic valve fracture performed under rapid ventricular pacing with a 24 mm true balloon. The fracture was confirmed with the release of the balloon waist and a sudden drop in inflation pressure. A transthoracic echo was obtained 30 days post-procedure, which showed similar hemodynamics, and her symptoms were improved. A preemptive alcohol septal ablation prior to TMVR has been reported mostly in patients with severe MAC and in some patients undergoing valve-involved TMVR. This case was novel since it involved a patient with mild dynamic LVOT obstruction at baseline undergoing valve-involved TMVR with a bioprosthetic valve fracture due to the small size and high residual gradients. Other strategies like the Lampoon strategy and a bailout alcohol septal ablation have been employed as potential solutions to prevent iatrogenic LVOT obstruction. The Lampoon procedure is technically challenging and few operators have the experience to perform this procedure. An alcohol septal ablation as a bailout strategy has been reported, but mortality remains high.